and we'll try to make up the time, and I request all the speakers to be in time. All these noises are going to be there. So are we all settled? Those who would like to have a coffee outside, they can go. I welcome you on behalf of Vidarbha Ophthalmic Society, one of the most happening society in central India. And my colleagues are with me, Dr. Shubhangi, Viral, and Prashant Bavankule is not here. My boss, ND Patil, has also reached. So whoever it is, we are all welcome you here, and I'll request my colleague Shubhangi to please take over and start the proceedings.
A very good afternoon to everyone. Thank AIOS for giving us this first session of Vidarbha Ophthalmic Society. Dr. Murtaza is there. So Dr. Murtaza will be talking to us on peripheral ulcerative keratitis, infectious and non-infectious. Dr. Milind is not there. Gunjan? Oh, sorry.
Who is the next speaker? Please load your slides. Yeah, Murtaza, you can go ahead.
Thank you, Team Scientific Committee, All India, and Vidarbha Ophthalmic Society for giving me this opportunity. So I will be presenting my talk on peripheral ulcerative keratitis. So whether it is infectious or non-infectious, let us clear after this topic. So no financial disclosure. So what is PUK? So apart from its peripheral location, it is a rare inflammatory condition of the eye and associated with autoimmune diseases, and nearly about 50% cases are associated with collagen vascular disorder. And sometimes this peripheral lesion can be an initial presentation of systemic disease like granulomatosis with polyangiitis GPA or polyarteritis nodosa. So whenever the PUK name comes to our mind, and what we see a classical picture as a crescentic shaped perilimbal ulceration with subepithelial infiltrate at the overhanging edge. And the progression is mostly circumferential, whereas it can be a centrimetal also. So associated features, what we can see in a PUK is a presence of plus minus scleritis. So whenever a systemic involvement is there in PUK, you will get a scleritis because of involvement of systemic vessels. Then you can also get an antechamber reaction that can lead to a hypopyon in case of a peripheral ulcerative lesion. Now how to manage is to know the etiology. Now before starting management of a peripheral ulcerative lesion, one should be thorough with what the investigations and to know what is the etiology behind it. Because systemic associations are there, and PUK in case of rheumatoid arthritis suggests switch from synovial microvasculitis to systemic vasculitis. As well as both PUK and scleritis association can be lethal, and the survival rate is less than 75% in case of relapsing polychondritis. Also, in some cases, PUK can be a very rapidly progressing, leading to perforation of the cornea. So what are the possible etiologies? So the etiology can be classified into local as well as systemic. Now coming to the local causes, what can give rise to a PUK-like picture? So it can be infectious. Bacterial causes like streptococcus, gonorrhea, Moraxella, Haemophilus, fungal, viral, and acanthamoeba. You can see in this picture the peripheral ulcerative lesion and corneal scraping giving us to a fungal filaments. As well as adjacent picture, if you don't do a corneal sensation test, then you will probably miss the herpes keratitis in this case. Now coming to the non-infectious causes. So non-infectious causes are traumatic due to chemical injury, burns, which can lead to limbal stem cell deficiency, eyelid and eyelashes abnormalities like entropion, ectropion, misdirected lashes, lack of thalamus, neurotropic keratitis where the healing is delayed and you should pick up early, and local autoimmune allograft rejection. This was a case of exposure keratopathy, particularly involving the inferior corneal limbus with superficial vascularization. And this case was managed just by lubricants and antibiotics, and you can see it started resolving within just 3 weeks. So there also can be another entity called as keratoconjunctiva or dry eye syndrome, where there can be due to stromal dehydration you can get a Dalen, and there can be a peripheral edge infiltrate, and then you can miss it as a PUK. One should see the loss of corneal luster and should also evaluate for the low tier meniscus in this case. Treatment will be aggressive lubrication and immunosuppression support in cross consultation with a rheumatologist. Then this is a classical picture of a marginal keratitis. You can see wherever the lid is touching the cornea, you can get such a picture of a marginal keratitis. Important to note the presence of a lucid interval. And the management, and this case should not be can be easily managed with a general ophthalmologist. Management will be with a lid hygiene, meibomian gland dysfunction treatment, lubricant, and low-dose steroids. Now coming to the systemic causes. So the systemic causes can be autoimmune, dermatological, inflammatory malignancies. In autoimmune, you can have rheumatoid arthritis, vaginous relapsing polychondritis, systemic lupus erythematosus, polyarthritis nodosa, Sjogren's, dermatology, and the list goes on. So the gamut of a Murren's, peripheral ulcerative lesion can be as severe as Murren's to as mild as just a chronic contactless user presenting to us with just a dot-like infiltrate. You can also misdiagnose as a degenerative condition with a PUK, degenerative condition like Terence marginal degeneration. Terence, usually you will have a lipid deposition at its advancing edge, and there will be superior limbus involvement. Whereas in PMCD, like perilous marginal degeneration, you will have inferior corneal thinning, and sometimes this thinning can be so advanced that it can give rise to a hydrops or a perforation also. So whether it is infectious or non-infectious, that is the question. So why we need to know whether it is infectious or not? Because steroids are the mainstay therapy in a non-infectious case, as well as 50% cases are associated with collagen vascular disorder that will need systemic immunosuppression. Also, one need to differentiate whether it is a Murren's or as a systemic immune PUK. So Murren's was described by Watson's criteria. There should be no scleral involvement. There is no scleral involvement in Murren's, and it is mostly idiopathic in nature. And Watson proposed the classification into 3 types: type 1, 2, and 3. So type 1 Murren's is usually bilateral and painful more than age 60. Type 2 is can be seen in young with more aggressive in nature and less painful. Type 3 is more of an indolent one. Whereas systemic immune PUK cases will have associated scleritis. And this picture is a lady with a systemic failure in case of a multi-drug resistant TB. And ultimately she succumbed to the systemic failure. So how to approach a patient with a PUK? So thorough history taking is necessary. Meticulous clinical workup. You should never fail to check the corneal sensation, tear film, meniscus, as well as adjacent lid and adnexa. Corneal scraping, yes, definitely. Whenever in doubt, you should do a corneal scraping and culture. And detailed systemic investigations when you suspect systemic cause of PUK like ESR, CRP, ANA blot, CBC, because you will be starting immunosuppression. Also, cross consultation with rheumatologists is very essential whenever you are suspecting a systemic cause of PUK. So, coming to some variable cases of PUK presentation. This was a lady of 55-year-old came to me with active PUK in her right eye, and other eye already lost and under phthisis. So there was a perforated peripheral ulcer in the superior limbus, and her ESR and CRP were raised. RF factor was found to be positive, and we did a crescentic graft, also familiar, very well known as banana grafting with cataract extraction, because she was having hypermature cataract. And we could be able to restore her vision. She was doing well on topical as well as systemic steroid. But after 2 months, we can see there again the edge started showing an active infiltrate here. So we stepped up the steroids and immunosuppression, and the patient got lost to follow. Then after 4 months, she again presented with a total AC collapse with central advancement of the ulcer. And at this time, we consulted with the rheumatologist, and she received some 5 doses of IV cyclophosphamide, that is endoxan, along with her anti-rheumatic drugs. And she underwent a penetrating keratoplasty. Importantly, I didn't remove the banana or the crescentic patch graft which I had placed previously, because it had got scarred very well and was blocking the conjunctival vessels to grow over the cornea. So as of now, this patient, she is doing well, and she is on topical as well as systemic steroids. Now, this is again a case of a 94-year-old gentleman who presented on day 1 with a very aggressive peripheral ulcerative lesion. However, his relatives were reluctant for patch grafting just on day 1. So again on day 2, when he presented, the melt had increased, and even the iris tissue prolapsed. And on day 3, he underwent a patch grafting. So he was doing well on topical as well as systemic low-dose steroids. But you can see on day 14, again the side port, even the side port started melting, and there was melting beyond the patch graft area as well as in the central part of the cornea also. So aggressive the nature was of melting. Now at this time we consulted rheumatologist that he will need a high dose immunosuppression. Initially he was reluctant because the age of the patient was 94. So, but then he gave a high dose immunosuppression therapy, and we did a regraft for this patient. And you can see after the regrafting and under cover of high dose immunosuppression, the eye eventually got quite well. This was a case of a 75-year-old male who presented with circumscribed corneal thinning. This was not a typical case of PUK. You can see circumscribed lesion with infiltrate at the margin, and we scraped it, but however the scraping was negative. Then we started on empirical antibiotics, cycloplegics, oral doxycycline, as he was having some immune gland dysfunction as well. However, on day 3 when he presented, again the melting had increased as well as the infiltration. So we continued with our treatment line, that antibiotics and cycloplegics. But on day 7 he perforated, and we had to take him for patch grafting. Now again on day 15 he came with loose sutures and active melting at this time. So we thought, no, there is something occult systemic involvement. So this time he tested positive for Sjogren as well as RA factor. Now after starting only with immunosuppression, the graft melting was arrested, and he's doing well as of now on this topical as well as systemic immunosuppression. So this presented like a not a typical case of PUK, but a mixed picture secondary to Sjogren's. So this was a case of a 18-year-old boy who was referred to me for a perforated cornea at the limbus, and he didn't give any positive history of trauma.
Can you wind up, Murtaza? The time is up.
Yes, ma'am. So just madam, just please. So the lid eversion showed grade 2 papillae, and we took him for surgery. So we found that there was a profound tissue loss, and he underwent a 4 mm patch graft for this tissue loss. And he did well initially for first 2 weeks. Then again on day 16, he presented with loose sutures and active corneal melting. So this time he tested positive for anti-CCP. And after consultation with the rheumatologist, we put him on pulse methylprednisolone therapy, 500 milligram just for 2 days. And then only the graft got settled well. This was a very recent case which I was managing.
Just sum up.
I
Yes,
think,
madam.
yeah. Please
Just,
don't
madam,
extend your
yes.
time, because
Yeah,
we
this
have-
was recently managing this case, bilateral Murans. He was not responding on topical steroid and lubricant. So just I did a tarsorrhaphy, depending upon the limbus involvement. And you can see that after day 7, the congestion had gone, and even the active ulceration showed very good progress, like the progression stopped. So you can see the change in the staining pattern also. Just only a simple tarsorrhaphy can work wonders in such cases. So now to sum up, so steroids are the mainstay therapy, but however one should plan a long-term immunosuppression in such cases. And the biological agents, these are not new, and these are in use since 2001, and these are good in refractive cases. Surgical procedure, tectonic, and you can do well, but you need to put the patient on immunosuppression. So my take-home message will be just that clinical presentation of PUK can be variable, and that should be a specialized care, and always these cases should be collaborated with a rheumatologist, because these patients definitely need a long-term immunosuppression. Thank you.
Yeah,
Thank you so
thanks.
much, Murtaza. Your excellent presentations, but you should stick to your time. Next.
You very nicely brought up the control of systemic autoimmune disease, which has to be done. In one of my patients of RK, I was surprised after a month she came with a scleral melt. And I said, I didn't do anything to the sclera. Why did she come with a scleral melt? So we investigated. So she had a rheumatoid arthritis, which had flared up. And that is how she. So once the rheumatoid arthritis was taken care, the scleral melt settled.
Sometimes, madam, post even pterygium surgery also
Yes. Yes.
scleral melt very actively in such cases.
Yes.
Yeah, anti-inflammatory. People are continuously using these anti-inflammatories. I think one must be very careful how much you can use and how far you should use that.
Well,
Yeah, next.
Excellent talk, Dr. Murtaza. May I invite the next speaker, Dr. Gunjan Rathi, a well-known oculoplastic surgeon of the Central India, to tell us more about the masquerades of orbit and oculoplasty. All over to you, Gunjan. Please stick to your timings, Gunjan.
Maybe I'll start the timer myself. It's there?
It's there, it's there.
Okay. Good afternoon, everybody. My name is Dr. Gunjan Rathi, and my topic for today is mascarades in orbit and oculoplasty. At the outset, I would like to thank the Asia Pacific Society, All India Ophthalmic Society, and Vidarbha Ophthalmic Society to provide me with this opportunity. Now, what are the mascarades that we are discussing today? Let me explain this to you with the case of this 13-year-old female child, a syndromic child, who presented to me with a right eye upper lid mass. Now, the parents said that she had developed this mass in the last 15 days. It was slowly growing, painless, and when I examined her, it was a papillomatous fleshy pink mass which appeared to be arising from the palpebral conjunctiva of the right eye upper lid. She also had developed ptosis in the same duration, which appeared to be mechanical ptosis. Now, it appeared like a viral papilloma to me. I asked them to get a mass excision biopsy, so gave them blood tests and asked them to come back. Now, they came back in 15 days, and what I saw was this. The mass had increased so much in size that she was not able to open her eyes. She has also developed proptosis in the same duration. Now, a rapidly growing mass in a child cannot be a good sign. So I went ahead with MRI orbit, and what I saw was the mass had now extended into the orbit superiorly. With this, I went ahead, did a mass biopsy, sent it for histopathology, and it came out to be rhabdomyosarcoma. The patient was then sent to the pediatric oncologist, and she needed chemotherapy and radiotherapy for this. Post that, she has been doing well. Now, these are the cases that we are talking about today. Cases which actually appear to be benign, inflammatory, or infective in the beginning, but actually turn out to be more serious in the form of malignancies. These are the wolves which actually appear under the sheep's skin. Now, what are we supposed to do when we deal with such cases? Early diagnosis. The earlier you diagnose them, the better it is for us so that we can treat them early. For the ease of understanding, I'm dividing the further part into lid and orbital cases. So coming to the lid pathologies, this gentleman is a 70-year-old man who came to me with a right eye upper lid mass since 6 months, again painless. He was actually referred to me by a colleague ophthalmologist who had done an INC, incision curettage, on him the previous day and said he could not remove it completely, so referred him to me. What I saw was a fractured tarsal plate with a lot of cheesy material on the conjunctival surface. But along with that, what I also saw was a nodular swelling at the lid margin. When I went back in history, asked for details, the patient then said that 3 years back, he has removed this mass, he has gotten it removed twice, and none of the times biopsy was done. So now we were looking at a recurrent mass in an elderly individual, which also was presenting with a lid margin nodule. This was definitely not a routine chalazion. So I went ahead with a wide margin excision biopsy in frozen section, did the lid reconstruction with the help of Tenzel flap, and sent the sample for histopathology. It came out to be sebaceous gland carcinoma. This is the patient's photo 3 days post-operatively. Oncologist opinion was sought, and because the mass was removed in toto, only observation was advised for him. Now, what could have been done in this case? Maybe if you have already done an incision curettage and you feel that it is unusual, you can send the sample for biopsy then and there, instead of waiting. Now, because chalazion is a common thing, let me just explain it to you a little bit, how to differentiate between them. So a typical chalazion generally is present in younger individuals with a round, cystic, well-defined swelling, generally limited to the extent of the tarsal plate. On eversion, what you see is just thinning of the conjunctiva with some pinkish gray discoloration. And sometimes a small granuloma may be present in case if it is a burst chalazion. Other than that, in case if you feel it is in an elderly individual, the mass is rounded, ill-defined, firm. It is going beyond the extent of the tarsal plate. On eversion, if you see that there's a lot of cheesy white material which is stuck on the inner surface, which is going even beyond the extent of the mass, or some papillomatous mass or some kind of mass which is growing from the conjunctiva. All these things are atypical, and all these things warrant biopsy. Coming to the orbital pathologies, this is a 33-year-old female who presented to me saying that her left eye appeared to be larger than the right eye. She was a known case of thyroid for 6 years, on medication, doing well. She was also consulting an ophthalmologist where lubricants were given to her, and she was told that her eyes might look bigger than normal because she might be having thyroid eye disease. But after looking at her, what I found unusual was she was having an inferior dystopia instead of an axial proptosis. Also, the other signs of thyroid were also absent. Because it appeared confusing, I went ahead with a contrast-enhanced CT scan, and what I saw was a mass pushing the eyeball down, lying between the roof of the orbit and the eyeball. Now I went ahead with superior orbitotomy with mass excision biopsy, sent it for histopathology, and it came out to be pleomorphic adenoma of the adnexal glands, which is actually something rare. And this is the patient 10 days post-operatively. Now again, oncologist opinion was taken, and because the mask was removed in toto, all she needed was observation. So how do we differentiate between an exophthalmos and proptosis because of other cases? An exophthalmos will be present generally as an axial proptosis with other signs of thyroid in the form of lid retraction, temporal flare, upper or lower scleral show, and also lid lag. These patients also generally have a neck swelling, which might be absent in the other cases of proptosis due to other causes, and then you will be able to differentiate. With this, let me just reach the end. Let's recap whatever we have learned about the wolf that we were talking about. First, when in doubt, frequently follow up the patient. If you follow up the patient, keep on a close follow-up. In 2 or 3 sittings, you will understand if you feel that the case is atypical. These are the times when you actually need to manage them urgently. Second, O for oncologist opinion, which is very important in these cases. Our treatment does not end at the removal of mass. We need to know what the prognosis of the case is, and in case if any further management in the form of chemo or radiotherapy will be required. L, that stands for leaving a 4 mm margin in lid masses and removing the mass in toto in case of orbital masses. Now this is important because if you do an incision biopsy instead of an excision biopsy, the chances of recurrence become high, firstly, and secondly, the chances that the patient may need radiotherapy or chemotherapy in future also increase. So we are reducing the prognosis of the case in general. And lastly, fast action. These are cancers that we are dealing with. So if we diagnose them early, we actually help in preserving the functionality of the eye and the eyelid. This helps us in providing them better cosmesis post-treatment because we do not have to salvage a lot of tissue. And lastly, it improves the prognosis of the case. So it is the quality of the life and the life expectancy of the patient that increases. So in the end, what I would like to say is the important thing to do is diagnose them early. That's all from my side today. Thank you so much for your patient listening.
Yeah, thank you, Gunjan. It's good that you stick to time. And it was really a teaching lecture. I would say
I'd like to ask one question.
Yeah, sure.
When you do an excision, you do the histopathology of the cut edges to see the
Yes, yes. So
malignancy free.
Yeah. So for I'll do histopathology also, and in some cases where the spread is a lot, like in sebaceous gland carcinomas or basal cell carcinomas, where the margins are not well defined, then a frozen section of the margins. So otherwise, for all cases, clear margins to be there on all 4 sides and the base also. That I do in all the cases to see them.
Because in the lid, we can't take a 4 mm. Can we take?
Yes, ma'am. So in the lid case, which I had shown, I've taken a 4 mm margin. For orbital cases, we have to remove it totally with the capsule. For all the lid cases, we generally can remove it with the margins. So that's what I do. So pentagonal wedge resection was done in the case which I saw.
We have an expert panel also. Anybody from the expert panel want to say? Dr. Patil, please, if you want to say something.
Come to the mic. Come to the mic.
Or you can take a chair and come here. Yes. May I, in between, the next speaker should be ready for his presentation.
Thank you, Dr. Gunjan. And whenever there is doubt, definitely do biopsy. Second is at the primary level, if you are in doubt, do the CT scan and the other blood investigations. And never leave the patient without doing anything. Just putting lubricant or something like that. Rather, you keep following very closely because all these tumors are very dangerous. May cause many other problems, and the patient may lose the eye as well as morbidity for the life as well. Thank you very much. Excellent.
Calazion, which is notorious one. Calazion in the middle age group is always notorious. It can present like anything, and if you try to remove it, there is always a problem later on, recurrence, or may turn out to be sebaceous gland carcinoma. Yeah.
Thank you, Gunjan. Let's go to the next speaker, Kavita. Please come forward to talk about infectious scleral abscess management. Again, your time is 10 minutes. So.
A very good afternoon. At the outset, thank you APAO, AIOS and my own VOS for giving me this opportunity to present infectious scleral abscess management. We all know characteristics of sclera being a very tough, and because of the composite nature it has, and also covered with episclera and sclera, along with low metabolic activity, avascular structure, and impermeable to infection. But if it happens, then it is disasters. We have all studied types of scleritis, be it anterior, when we classify again into diffuse or nodular, a posterior scleritis variant, necrotizing, non-necrotizing, and today we will be dealing a little bit on immune-mediated and infectious, which will again be divided in endogenous and exogenous variety. Now, immune-mediated, whenever we think of, take a proper history, which is going to be very important in the diagnosis of immune-mediated. Usually it have a bilateral presentation, and when we see on an examination, we can see a little bit thinning of the sclera and a bluish hue which can be seen. There are usually signs of remission when the disease is been at the remission stage, and it usually responds to the corticosteroid treatment. When we talk about infectious scleral abscess, it is less compared to the immune-mediated, and it has been reported almost about 15% of cases. They are divided into endogenous and exogenous. Endo means whenever there is an infection, systemic infection in the body, be it a syphilis or tuberculosis, the presentation could be infectious, systemic infectious. And when exogenous means whenever you are having any trauma because of which the scleral abscess has been there, or extensions from the ocular structures, be it adnexa, be it a cornea or a retinal structure. And post-trauma, post-surgical, where it could be because of any of the surgeries like cataract, pterygium or adnexa. When we also differentiate between them, when we examine it on examination, you have to note the purulent exudates in infectious, and it is not so into the immune-mediated. And during investigation, make sure that in immune-mediated you do note RA factor, ANA factor, P ANCA and others, which they are not present or positive into the infectious variety. This is an example of nodular scleritis. It was because of the viral etiology and which was being treated by steroids and antivirals. This is a flow chart which I have downloaded from a study where it has nicely represented the immune and the infectious etiology. Immune we have already discussed. Now infectious etiology, when you see that when you have taken the sample, send it for the culture and sensitivity. If you get something, then it's good. If you have not got, you can repeat the same thing again. Do send it again for the culture and sensitivity. Even after, if you are getting nothing, again go back, have an ocular examination, look for any scars or anything which will give a clue for probably an viral etiology. If not, the patient is giving a history of trauma or something, go for antifungal presentations. If not these all, then you can still start them on steroid therapy, masking the immune pathology. Also a note on posterior scleritis. We all know that it has not been seen from front, but yes, B-scan usually helps us to come to a diagnosis of posterior scleritis and fundus examination. Now, should we intervene, and when to intervene? Yes, it is very necessary that whenever you are having multiple abscesses, if you see, it's better to go ahead and do a surgery debridement. There has been multiple studies which show that you should go ahead and do a thorough scleral patch graft or an surgical intervention to prevent the globe. Now, why should we intervene? It has been said, and we all know that scleral abscess is a destructive, suppurative nature and has very poor antibiotic penetration. And it can lead to devastating complications like end-off and pan-off, and we can lose the globe. Now, these are the few examples where it was a large corneoscleral melt which we can see with an iris seen through. Now here the surgeon has taken a nice large corneoscleral graft, and we can see that after healing the patient's globe has been properly intact, and we can further do any other surgeries to have a better vision. In a similar case of scleral secondary to the retinal surgery, the infected scleral buccal, here also they have removed this agent, the scleral buccal, plated it on the blood agar, looked for the organism, and here when the bed is not so good, they have again applied a scleral patch graft along with the antibiotics. Whenever you see an offending agent, be it any devices, it is better to remove it off and to save the globe. As I said, there are many theories which do say that you have to intervene early in cases of a large scleral abscess. So you can use a cryo or a lamellar or a PK, as we have already seen, for the better outcome of the patients. If we don't, then it could lead into a enucleation or evisceration. So early and repetitive surgical debridement is heavily advocated in scleral abscess patients. A note on masculine scleritis. It has been very rare, but yes, we should also have that in point, that when these things are not working, are we looking for something else? So there are very few cases, 2 or 3 reported as in masculine scleritis. So my take home message will be, if it is not responding, do an early intervention to have a better outcome. Thank you.
Yeah, there is a question from the audience. You can, yeah. Expert panel, Dr. Subodh, yes.
Madam, I would like to ask, when do you start antimetabolites like tacrolimus or cyclosporine in a non-infectious scleritis?
Sir, I think
Yes.
whenever you see that the patient is having higher disease in case of immune mediated, it is better to start along with the corticosteroids and the topical steroids.
No, like clinically seeing, like if you're used NSAIDs, also the corticosteroids,
Take a chair
then
and-
how long you wait for the disease to proceed and then you start with the tacrolimus or the cyclosporine? Like
Sir,
what do you see on clinical things?
Oral we are talking about?
No, topical.
So topical you can start. Tacrolimus topical we can start.
Okay, thank you. And what about biologics nowadays? They are saying many things about
Yeah.
biologics.
In case of topical, sir?
Yes, sir.
So you can, there are not many theories about the biological indicators and all, but yes, tacrolimus or along with the steroids, yeah, you can go ahead
Okay.
at the first instance.
Thank
So any autoimmune now biologics are going to be there. So we have to be ready,
As
Humira.
we
or-
take the corneal, scraping, the similar manner do you take the scleral scraping?
Yes, ma'am. And whenever you see any offending agent, it is better to remove that and plate it on agar. And if you see that the bed is not good, it is better to put a patch graft of anything so that you can save the globe.
Okay. That case you had shown, the corneal graft only was put on cornea and sclera,
Yes,
isn't
yes,
it?
ma'am. It is a large corneal sclera.
Okay, yeah. Good presentation.
Thank you so much. The next speaker is Shamik.
Very good afternoon, one and
Yeah,
all.
yeah.
At the outset, I'd like to thank the AIOC 2025 and my own Vidarbha Ophthalmic Society for giving me this opportunity to speak on this podium about ocular infections, and especially I'll be talking about presumed ocular tuberculosis and the role of AKT in managing the same. So as we all know, tuberculosis, Mycobacterium tuberculosis is the major cause for infectious diseases, especially so in regions which are endemic to tuberculosis. Almost more than a third of these patients of infectious uveitis turn out to be Mycobacterium tuberculosis. And a third of mycobacterial tuberculosis uveitis would end up with a visual acuity far less than what most of us don't even want to expect. It's less than 3/60. And a third of these patients tend to develop other comorbidities related to the uveitis, like glaucoma, secondary glaucomas, and macular disease, including the scarring of the retina. So the definitive diagnosis, as they say, is elusive, but I say I would want to rephrase this particular line and say that it's basically our ignorance towards the presence of Mycobacterium tuberculosis as a major cause of uveitis. And that's what is very obvious from the way and the pattern in which uveitis is mostly treated in our part of the world. Despite the fact that India remains the biggest tuberculosis endemic region in the entire world. So the cornerstone for investigation has always been the Mantoux test, the skin test, skin tuberculin test. And a strong positive Mantoux, as they say, is a definite sign of an exposure of the patient to tuberculosis, Mycobacterium tuberculosis, and uveitis in such patients. You can easily say that if there is a strong positive Mantoux, meaning more than 20 millimeters of induration, you can be very sure about it. But in cases which are ambiguous, Dr. Ratinam, my mentor, she always says that do a booster MANTU. I mean, she relies on MANTU that very much to again go on to prove that this is a case of tuberculosis. So, but still, if there is ambiguity, then we have the IGRA tests. Especially in the endemic regions, the positivity of IGRA is a very, very high specificity, almost 70 to 80% specificity, as far as diagnosis of MTB uveitis is concerned. Usually, tubercular uveitis doesn't present itself in a very fulminant fashion, very rare. Usually, it goes on over days, weeks, and months when the disease process starts affecting the patient's normal life, and signs and symptoms become very, very obvious. Likewise, the inflammatory markers also don't show a very increased number. It's a moderately high ESR, a moderately high C-reactive protein, and again, that is kind of with a positive skin test and an IGRA test, you are sure that you are looking at a case of Mycobacterium tuberculosis uveitis. And of course, if you can prove pulmonary or extrapulmonary tuberculosis, then more or less your diagnosis is confirmed, and you can proceed with the treatment of the uveitis with AKT. The PCR tests of ocular fluid is again catching up. It's slightly demanding, but then still, if it is proven, then it is a 100% bullseye, as you would call it, and you can initiate your treatment to treat the uveitis by putting the patient on anti-cox treatment. But what drives most of us when we are treating patients with uveitis is the classical clinical findings that you see. I picked up these slides from one of the uveitis group. If you see these multiple tiny nodular lesions in the conjunctiva or a painful localized inflammatory nodule on the sclera, the fleshy, greasy type of keratic precipitates with iris nodules, or as Dr. Amod Gupta has and his group has clearly shown us, a broad-based posterior synechia, or if you have an inflammatory involvement of the optic nerve presenting as disc edema, a well-defined elevated lesion with peripapillary fluid and hemorrhages causing disc edema and vision loss, or if you see these subtle RP level lesions which have hyper autofluorescent margins, or if you see a solitary elevated choroidal lesion, a choroidal lesion with exudative detachment, or these multiple yellowish choroidal tubercles with central clearing, or periphlebitis or occlusive phlebitis, as you can see in the slide, or a branch vein occlusion which is resulting from perivascular inflammation. So these are some of the cases where you can be sure that you are looking at, you should have a very high index of suspicion that the patient is suffering from tuberculosis, and the uveitis is basically because of that. Pathomechanisms, there are many, but what is proven is that probably the tuberculosis either involves because of direct invasion, or it is the induction of specific antiretinal immune response to the Mycobacterium tuberculosis antigen, or a combination of both. Here I would like to stress upon the role of retinal pigment epithelium in somehow controlling the spread of Mycobacterium tuberculosis in the eye. It not just incites the inflammatory cascade, but it also regulates how much inflammation is drawn towards controlling that MTB without damaging the ocular tissue. So RP does play a very important role. And of course, the retinal vasculature also, the blood retinal barrier, a part of that also limits the spread of the disease. And you will see these vasculitides and all in tuberculosis primarily because of the inflammatory response, the blood vessel lining, actually the retinal blood vessel lining that it throws up. Again, the same picture telling us how the T cells and the cytokines are liberated to control and limit the spread of the disease. And what's important is that tuberculosis doesn't kind of present in a very classical manner. It presents in variable phenotypes. So that's another reason why at times you get confused and you're not very sure. There is not a perfect clinical sign that you could say, okay, this is tuberculosis. And of course, a lack of a proper investigative tool that you can 100% trust. But in any case, different criteria have been adopted by different groups, the Sun group, the COTS group, the Gupta et al. Group, and they have all kind of told us what all you should do when you are suspecting uveitis because of MTB. Histopathologic isolation, positive IGRA, MANTU test, serology that rules out other infective disorder etiologies, and also to rule out sarcoidosis, because sarcoidosis is the closest differential diagnosis to tubercular uveitis. Chest radiography, and of course to try to confirm extrapulmonary COX. So from diagnosis, let's move on to the treatment part. Of course, a clear response to AKT in a case of uveitis is the most, that is the clearest sign that you are treating a patient with uveitis. There can be no other thing that you start the patient on AKT and the uveitis resolves. I think that is the clinching diagnosis that you are treating a patient with uveitis, and then you should not let it go and continue all the way. Steroids and immunosuppression are the cornerstones for treating any uveitis. And there are multiple studies wherein they have actually proven cases of mycobacterial tuberculosis related uveitis, which they have treated solely by treating the patient with antibiotics. And there have been multiple studies where they have shown how merely treating with steroids has been detrimental to the cause of treating TB uveitis. But more or less, if you treat the patient with AKT, on the contrary, if you treat the patient with AKT, your chances of 100% success in managing the uveitis, which is related to TB, is there. And there are so many studies that go on to say that. So there is a definite role of treating the patients where you are even suspecting a patient with Mycobacterium tubercular infection with AKT. I think you are doing well by treating the patients this one. And of course, as I said, the problems are because there is no gold standard diagnostic test, and the variable phenotypes with which the TB presents, and lack of awareness within our own fraternity also leads to lack of proper treatment. So what are the drugs? Basically, the traditional treatment is the 4-drug treatment. You start off with the 4 drugs in the initial 2 months, and then there is a maintenance phase of 4 months. WHO also recommends a 4-month ATT treatment, 2 months of isoniazid, rifampicin, moxifloxacin and pyrazinamide, followed by all the other drugs except pyrazinamide for the next 2 months. So this is another way. But most of the groups that have been studying TB uveitis always propose that you try to extend the treatment. Once you get a good response with AKT, don't stop at 6 months. Continue for 9 months or 12 months, because that is where you are able to then control the disease properly, and the chances of relapse are far less if you are treated them for a sufficiently long period of time. And there are so many online calculators which you could use that I have mentioned it one over there to find out the median score and then decide whether to recommend the patient for AKT or not. Use of systemic steroids concomitantly with AKT is definitely a good way of treating TB uveitis. You can't do without the steroids, but first control the infection and then start with anti-inflammation. That's my basic take home. And there are so many other drugs which are now available in our arsenal to manage TB uveitis. I rather not go into that. That's beyond the scope of this topic. I thank you for your patient listening.
Shamik, I just wanted to ask one thing. Because these drugs are potentially toxic and have their side effects. So yes, what is your protocol for following them up for avoiding the ethambutol toxicity?
Ma'am, basically ethambutol toxicity, yes, we should have. Whenever we start the patient, the basic thing is that follow up the patient very rigorously. You can't just leave the patient just like that. Now there is a watchdog from our own government of India who, once they start the patient on AKT, they are following them up very nicely. If the patient complains of any vision related thing, it could be because of uveitis, because there are flare-ups which are happening. But one needs to have that thing in the mind that we are treating the patient with ethambutol for a long period of time. So there can be a chance of toxicity. So follow-up, I think, ma'am, should be the right thing to do.
Even the dose calculation, because these are these toxicity occur because of the cumulative effect dose. Of the drug. So yes, sometimes that is exceeded, and yes, patients suffer permanent visual loss because of the treatment.
And so as a rule, ma'am, there is one thing that I wanted to add. all of us are doctors and we are well versed with treating patients with AKT, all right. But I think the chest physicians do a very good job with the management of such patients. They know, they can identify the side effects of these drugs, and so always when you are starting the patient on AKT, it's a good idea to involve an physician in the process. Same thing with management with immunosuppressives also. I think if you have a good rheumatologist friend and a chest physician with you, I think you are doing well in treating your patients properly.
I think you made a point, because now drug resistance is becoming very common. And now next speaker is Dr. Shamik Mukaddam. He's going to talk to us about endophthalmitis management, early intervention with complete vitrectomy. Over to Shamik. Time.
Thank you very much.
Mic पर नहीं चालू
दोनों चालू ठीक. I would like to thank the AIOC for giving me this opportunity, and also my very own VOS for giving me this opportunity to be here. I would straight away go to the topic of today's discussion, endophthalmitis management. We all know about endophthalmitis. It is a medical emergency caused by infection of tissues or fluids inside the eyeball. It is a severe purulent intraocular inflammation. Early detection and early initiation of treatment is the key to the management. And the types we all know, it is exogenous, either post-trauma or post-surgical, or it could be endogenous. Principles of theory are either like so: killing the organism, removing the inflammatory debris, treating complications and preventing future complications of the infection, and intervene as soon as possible. So we all go on to the landmark study, that was the endophthalmitis vitrectomy study, which was done in 1990 to 94. And it was done to determine whether it is necessary in acute post-operative endophthalmitis to use systemic antibiotics or perform routine immediate vitrectomy. So what the results showed us was statistical visual improvement in PPV for visual acuity in PL or worse, and no significant improvement regardless of approach in group of patients with vision, hand movement or better. And they also showed that systemic antibiotics didn't show significant variation in visual improvement. However, there were limitations to this, and they were the use of non-contemporary vitrectomy equipment and conservative nature of the vitrectomy, which was mainly doing a core vitrectomy and avoiding the peripheral vitreous to be cut at all. So then we come to why vitrectomy in endophthalmitis. It reduces the inflammatory load and the bacterial load. It gives us more specimen for microbiology, gives direct visualization of the retina, better availability of antibiotics, and improves oxygenation of the retina. Then why early vitrectomy? So it is immediate treatment, prophylaxis at preventing possible complications, risk of surgery reduced because we have a better media, because the prolongation of the disease gives us corneal edema, corneal haze, and it makes it difficult to go inside the eye and try to do a complete vitrectomy. And it also prevents tissue fragility. Then why a complete vitrectomy? A complete removal of, it helps in complete removal of inflammatory material, that is the pus, and it gives better penetration of the antibiotics, in addition to the oxygenation of the retina and other things that I just enumerated earlier. So there have been studies which have shown complete and early vitrectomy for endophthalmitis. The CEVE study, studies which have shown early PPV has very good results visually, and a few others have also shown no additional benefits than intravitreal antibiotics alone. But then this CEV was proposed by Kuhn and Ginny, and they showed very good results in their small cohort. And other authors have also shown good results with this. In addition, they also have something called a CEV plus, where they do additional lavage of the vitreous in case there is a recurrence of inflammatory debris inside the eye. So what were the protocols that they followed? It was if they see endophthalmitis, immediately they'll look at whether there is a good reflex. Then if there is a good reflex, proceed with medical therapy and observe patient closely for about 24 hours. If there is improvement, continue with medical therapy. If no improvement, then we go ahead with vitrectomy. However, if there is no good reflex, straight away go for vitrectomy. And these studies have shown that CEV gives us good final visual acuity of almost 20, 40 or greater with early vitrectomies and complete vitrectomy. There is this big question of whether to remove the IOL or not to remove the IOL. Earlier, we used to remove IOL in practically every endophthalmitis that we used to see, but then there have been reports and studies where they have shown that removing an IOL is to be best avoided, especially in acute endophthalmitis, and in chronic we need to remove it because the inflammatory and infective material is right there in the capsular bag, and it is stuck onto the posterior capsule, surface of the IOL. So it is better to do an early explantation of the IOL and intervention along with intravitreal antibiotics. Our very own endophthalmitis management study group, which is based from India with Dr. T.P. Das and his group heading the study, and they have decided to go ahead with this prospective randomized multi-center study of post cataract surgery acute endophthalmitis with IOL implantation. And the primary intervention, what they are planning to do is intravitreal injection alone or vitrectomy based on something called as an inflammatory score. And the other thing is primary intravitreal antibiotics, which is randomized to either vancomycin plus ceftazidime or vancomycin plus imipenem. They have come out, this study was started in 2021, and they have these interim analysis of the EMS which is already out. And they did mention that we need to consider the inflammatory score along with the presenting vision when we are to go ahead with the treatment and consider the treatment at all. And based on the availability, we also need to go ahead with susceptibility testing of all gram-negative bacterial growth whenever we have it. And if not, if we don't have the availability of such susceptibility testing, we should do a combination of vancomycin and colistin. So these were the interim results that are just out, but we still need to understand what would be their final outcome of the EMS, and we'll be getting it sooner. But then to conclude, we have CEV is a safe and effective initial treatment, and systemic antibiotics and retreatment, that is CEV plus of recurrent media opacification, this is recovery by almost 50%. IOL explantation in late chronic endophthalmitis definitely to be done whenever we come across one case of late endophthalmitis. And as I just mentioned, EMS group outcomes would give us better insight to the use of newer microbiological tests and antibiotics used. Thank you. Sir, it is something, as I just mentioned, we need to just go ahead as soon as we know that we are looking at a case of it's an endophthalmitis, as soon as possible. That is what we have started seeing. And vitrectomy also, earlier we used to say we should do just the core vitrectomy, inject some intravitreal antibiotics. But nowadays we are moving more and more towards a complete vitrectomy. And the protocols that they have set up with the complete and early vitrectomy group is right from the corneal and the AC management to the vitreous management. And whenever we see that the retina is a little more fragile, or there is ischemic part of the retina on vitrectomy, we tend to go around that area and avoid direct vitrectomy over it. So there are protocols which have been set up by the CVE group, and we have got really good results. And they also mentioned that including silicone oil gives a good prevention of further growth of bacterial organisms around it.
I think CV means induction of posterior vitreous detachment as well. So it has to be a guarded posterior vitreous detachment to be induced. And whenever we suspect a case of as a endophthalmitis, once we are sure that it's no longer just an inflammatory component that is TAS. Previously, we used to do just an aqueous tap and still inject intravitreals and then wait for, unless the disease forced us, we would not go for a vitreous surgery. But now the concept is, if I know that it is not a TAS in next 6-8 hours, instead of doing a intravitreal antibiotic, I will go directly with vitrectomy, because the advantage is I get a adequate sample for culture sensitivity as well as you have removed whatever the load of the organism is, and at that point of time retina is not edematous and necrotic, so you can induce a PVD and near total vitrectomy is possible. So that is the advantage of this particular thing. So you should be doing a vitrectomy as a primary procedure of choice wherever facility is available. Yeah.
Vancomycin, yes.
Yeah, any drug which we are
Each drug
using,
which
of
is-
course,
Yeah,
it has to
even-
be used in a proper dose.
I think it is the protocol is very clear. As soon as the peripheral center has started, is diagnosed it, intravitreal you should give if you can give, and go for early vitrectomy. Earlier you do it, better you have results.
Yes, sir. Yes.
And that's very well made. Thank you so much, Shamik. No, late onset is different. I'm talking about acute.
Even for late, we should go ahead with early vitrectomy and IOL removal.
See,
because we know that the organisms are within the bag, and we need to remove the IOL, which is the cause. And many a times, even fungal endophthalmitis, which is again a delayed or chronic kind of endophthalmitis, it is best to remove the bag, because we really don't
Then
know
we have
where
to
this
remove, explant
fungus
the IOL.
is.
No, I think I would put it in a right way. If it is a chronic presentation that is happening after few weeks of quiescence, post-operatively, and you now have a flare of inflammation, first again decide whether it is inflammatory versus an infective. Once you are sure it's an infective, again you go for a primary vitrectomy instead of just doing a vitreous biopsy and trying to treat it with intravitreal antibiotics. So vitrectomy is the way to go. Now, should we do an IOL explantation along with it is a matter of debate. I would always like to preserve the IOL till the organisms forces me. So it would be always for me a second surgery, means if there is a inflammation which is not getting under control, then as a secondary procedure. So first procedure try to salvage, because why did the whole primary surgery and patient undergo? So, and not necessarily that every time it can be an acne which is inside the bag. So that is the thing. So you should give benefit of doubt. Primary surgery try avoid, unless.
I had 2-3 cases recently only, last 6 months back, for developmental cataract, especially in younger age group. I did cataract surgery, and after just 3 weeks they were fine, and after 3 to 4 weeks they started developing hypopyon. Now in that case we did a ESR, and the ESR were very highly raised. So my colleague, retina colleague, said me that okay, we'll go ahead with 1 hourly steroid and Toba and Vigomox we added, and with that only in 2 days we got a little bit improvement. Then we just continued with the steroid and antibiotic combination, and it got like
Two things I would like
not
to.
developmental cataract. Developmental
Two
cataract.
things. Inadequate medication might have been the reason for that inflammation, because it's not uncommon in a pediatric case where the patients squeeze and they don't properly put hygiene, other things. So that is one of the reasons why in a
Immune
developmental
response
baby.
is
ESR
also
was a
strong.
consistent
Immune
factor.
response is also
Exactly.
strong.
Raise ESR was a consistent factor in all those cases.
Can be. Why not?
So-
Every inflammation has to be
And
having.
recently also one GMC case, sir has only operated, and we did this, and like he presented with a full chamber hypopyon, but
How old was the baby?
she was elderly, like 92 age, and she responded well again with the steroid regimen only. So
Let me caution you here. Once you have a full chamber hypopyon, I would never ever suggest, it's a contraindication of use of oral steroids. Now, if you feel that it is inflammation, still you feel it's an inflammation, you can give a trial of topical steroids 1 hourly. That is
Topical only.
sufficient.
Topical only
That
we
is what I
gave.
am saying. A
Topical only we
topical
gave
along with an
just
atropine.
for 1 day we gave, and
that
we
can help it. That's
saw
a
some
option.
improvement next day, and then we continued with that only.
Exactly,
So within
exactly.
7 days she is doing very well now.
And you should always do a B scan when you have total
B scan is most
hypopyon.
important.
Yeah,
Yes,
B
B
scan
scan
vitreous
is essential, because unless until you see how's the vitreous, because full chamber invariably will show
No,
vitritis.
B scan only showed anterior vitritis, like not posterior part was somewhat clear only. Only anterior in globe, in the anterior part only, there was so many cells and.
You have been lucky escaped, that I should say, but
Yeah.
I would think it otherwise.
I think you have to, every patient needs its special care, and you have to go by the case. The last speaker is Shilpi. Dr. Shilpi Narnavare will be talking to us about post-procedure red eye. And then we'll have some questions.
So good evening everyone. Thank you VOS, AIOS and APO for this opportunity. So I will be speaking on post-operative red eye. So any exaggerated inflammation after any procedure is always a nightmare for any surgeon. So first we have to look at the scenarios after the surgery. It can happen whether it is because of the surgical trauma in an eye which is predisposed, in sometimes in traumatic surgeries and cluster or single cases. So surgical trauma, other day you will see, yes, it depends upon the duration of the surgery, prolonged phaco time, iris chafing, posterior capsular tear, big pupils. These are the signs that you had surgical trauma during the surgery. While there are few predisposed eyes which will present later as exaggerated inflammation post surgery. Especially in diabetic patients, we see that up to 20% of all the cataract procedures are for the diabetic patients, and we get severe fibrinous reaction in 10% of these patients. 21% cases of these are of established endophthalmitis, which are culture positive in 79% and gram negative in 18.5% of the cases. While the major concern is inflammation in a traumatic surgery. It can be non-infectious or infectious. So this was a patient who was 25 years old male who presented with history of trauma 10 years back. There was epithelialized interior capsular rupture. Intra-op, it was uneventful surgery, but post-op he presented with AC cells of 2+, fundus, there was a hazy view. B-scan was done which showed minimal opacities on the high gain, and he was managed with topical steroids and cycloplegics, and a day later this was the picture. So this was a case of anterior chamber associated immune deviation, which is actually an immune protection to the eye and which interferes minimally with the vision. It avoids a harmful immune response to unique molecules which immune system never regards as self. We need to differentiate between TAS and endophthalmitis. TAS is a sterile post-op inflammation which happens because of the toxic damage due to the non-infectious substances which enters the anterior segment. It can happen as an isolated case or even in cluster. Clinical features are poor vision, hypopyon you may also get, fibrin or corneal edema. It can be confused with endophthalmitis, but differentiation is necessary as for TAS, steroids is the drug of choice, while for endophthalmitis, antibiotics are to be used. The major distinguishing features are that TAS is usually early onset. You will get limbus to limbus corneal edema. You will have some signs of iris damage. Usually the IOP is high and there is absence of vitritis on indirect ophthalmoscopy. But never ever, you should not ignore TAS also because it has its own sight-threatening complications like permanent corneal decompensation, intractable glaucoma and cystoid macular edema. Now, how to evaluate a case of inflammation? Always look at the history. Never ever ignore such history in any patient. If we go by the EVS study and the ESRS study, these are the clinical presentation. Red eye was never ever studied in ESCRS, but in EVS study, 82% of the patients, they presented with post-operative exaggerated red eye. So these are the various points where clinical examination we should always do. Visual acuity is important and must, not only because of from the medico-legal point of view, but because of the two major landmark studies. According to the ESCRS, visual acuity was never a criteria for taking the patient for vitrectomy. We have to check the adnexal evaluation like NLD evaluation, tear meniscus and also the conjunctiva. Slit lamp examination sometimes help us in giving whether the surgery was traumatic or not. there is any sutural infiltration or a leak. Corneal assessment is to be done for prognosis purpose also. Anterior chamber cell grading is to be done according to the sun grading system. Iris and pupillary reactions are important, but it may be masked because of the cycloplegics or because of the exudates. Positioning of the IOL helps you in determining whether the surgery was traumatic or not. IOP should always be done, and it should be always a sterile IOP by the applanation tonometry. Usually IOP is low in cases of endophthalmitis except when it is UGH, TAS or fungal endophthalmitis. Posterior SIGBIT evaluation is done on slit lamp biomicroscopy and also with the indirect ophthalmoscopy depending upon the grading given by the sun working group. B-scan is equally important as it shows the density of the vitreous opacities, whether vitreous membranes are present or not, presence of nucleus fragments or IOLs, choroidal detachment and chorioscleral involvement. So these are the various B scans which we should look for the various opacities, choroidal detachment, inflammation of the ocular coats. So how to manage? If you are not sure whether it is a TAS or endophthalmitis, never ever start with the oral steroids or no AC wash in such cases. Increase the frequency of the topical steroids and re-evaluate the patient after 4 to 6 hours. If still in doubt, treat it as an infective case and always treat it as a case of endophthalmitis. Microbiological investigations are important even if you are managing a patient medically. Either the aqueous tap or the vitreous tap, it has to be given. The isolation rate of vitreous tap is more compared to the aqueous tap. PCR has the more isolation rate. With the aqueous sample it is 84% and with the vitreous sample it is 92%. But remember, negative cultures does not rule out inflammation. Negative cultures can be seen in presence of the fastigious organisms, insufficient sampling or sterile endophthalmitis. If you still suspect that it is a case of endophthalmitis, always send a repeat culture. Vitrectomy, if has to be done, it should be diagnostic and therapeutic. Principle is to debulk as much as you can. So these are the few cases which I will share. It was a case of non-diabetic 73-year-old gentleman. He has a dark, hard brown cataract, uneventful surgery, and was advised subconjunctival antibiotics and oral steroids for inflammation at day 1. So this was the presenting picture on day 1. On slit lamp examination on the retroillumination, there was good glow and the vitreous was clear on indirect ophthalmoscopy. So diagnosis of traumatic uveitis or TAS was made. The treatment given was increase the frequency of the topical steroids and cycloplegics and stop oral steroids. 6 hours later, there was improvement in the AC reaction. So hypopyon does not necessarily mean infection. Retroillumination and indirect ophthalmoscopy ruled out the vitreous involvement, so that's why the diagnosis of TAS was made. This was another case. He was a gentleman post-vitrectomy with grade 3 nuclear cataract and had uneventful cataract surgery. On day 1, there was streak hypopyon, mild reaction, while on the B scan on 90 decibels gain, there was minimal opacities. So these are basically the residual silicone oil opacities in this patient. This patient was also treated with topical steroids and cycloplegics, and on follow-ups at 6 hours later, there was reducing inflammation, and at 24 hours, it was almost near normal. So post-vitrectomy eyes reacts more severely, and so also the young patients. This is another case, status post PRP and anti-VEGF. And at day 1, this was the picture. Trial of topical steroids and cycloplegics was given, and at day 2, this was the picture. So, any patient who has underwent vitrectomy, anti-VEGFs or any retinal treatment, they are more prone to severe reaction post-operatively. Not necessarily it can be a endophthalmitis. This is the another case who had traumatic surgery and had asteroid hyalosis preoperative. So day 1, this was the picture. B scan was done elsewhere at 70 decibels and it was interpreted as asteroid hyalosis. Patient was started on oral steroids and 3 hours later this was the picture. And when the B scan was done at 90 decibels, there were severe vitreous opacities. Diagnosis of acute endophthalmitis was made and patient was undertaken for the vitrectomy. In this case, this patient was diabetic under treatment and was given oral steroids for inflammation after the surgery. If you get this type of a picture, there is no role of oral steroids in such kind of a picture. So always take the patient for vitrectomy. Now, this is the last case, a non-diabetic pseudophakic patient who received anti-VEGF biosimilar for CNVM. This was the presenting picture at the referring surgeon at 6 hours. There was a hypopion, minimal reaction. The doctor thought it is a sterile inflammation and the topical steroids and cycloplegics were given. But 12 hours later, there was membrane hypopion increase and the patient was posted for vitrectomy and intravitreal antibiotics. So to summarize, any exaggerated post-op inflammation is real-time emergency. We should always do a thorough clinical examination. B scan should always be done at 90 decibels. If you are suspecting it's a TAS, you should treat it with intensive topical steroids and cycloplegics. If in doubt, always take a vitreous sample and try to do vitrectomy as much as possible and treat it with intravitreal antibiotics. Post anti-VEGF, it's very less likely that it will be a TAS or any other inflammation. Always treat the post anti-VEGF patients as endophthalmitis and take them for vitrectomy as soon as possible. Thank you.
Thank you so much. This is the last topic. And any questions now? Because we do have 5-10 minutes.
We always are in a denial mode when it comes to endophthalmitis. So I think one has to keep in mind the post-op loss of glow and all could be because of endophthalmitis. Most of us would like to believe that it is TAS. So that one thing delays the treatment sometimes.
You nailed it, ma'am. Basically, it's most of the times when we get as a vitreoretinal surgeons, the patients at a late stage, it is a denial mode. अरे सब अच्छा हुआ था, let me give trial of steroid देता हूँ, ये देता हूँ. Please don't do that. The moment you see inflammation which is more than acceptable for that type of surgery, traumatic surgery or a traumatic surgery you did, it is prudent to think it as an infective. A shot of intravitreal antibiotic is not going to harm as much as a shot of a oral steroid or an oral tablet of 10 milligram, 20 milligram which you are giving.
Yes, there is a question.
Sir, steroid tapering regimen in cases of pediatric or developmental cataract, like for normal cataract surgery, we taper steroids within 1 month or maybe 1.5 months. But for such cases, like for pediatric cases or congenital cases, do we taper steroids for longer time or like that?
2 months.
Minimum 2 months. So based upon like any systemic investigation or like for any general?
For a routine also.
For routine cases, all pediatric
for 2 months.
cataracts, you taper
tapering
steroid
doses.
for 2 months. Any choice of steroid, madam? Like only Predford or
I
like
give
prednisolone?
prednisolone acetate.
Acetate. Okay, thank you.
Questions.
So one question to Dr. Shamik Ambatkar sir. He said that in tubercular uveitis you have to start with the AKT, but even if there is no pulmonary tuberculosis, do you suggest AKT even if there is no extra any pulmonary or any extra pulmonary tuberculosis, only uveitis if you are suspecting?
So that's what the entire topic was about, the same thing. It need not be that the patient is having tubercular uveitis or suspected tubercular uveitis and the patient has a patch on the lungs. Tuberculosis presents itself in the eye itself in 22-25 different forms and with very rare presentation within the normal accepted organs. So we have to look for extrapulmonary tuberculosis, pulmonary tuberculosis, there is no doubt about it. But if your blood tests are, and the investigations that I mentioned, if they are recurrently telling you that this patient could be a patient with uveitis, then you have to start AKT. AKT has to be started if you are suspecting even clinically or without any, with the investigations telling you that there is a suspicion that probably that is there.
So both there is a terminology called presumed ocular tuberculosis. So where you do not have systemic evidence of it. So this is called a group of it. Very well, they have given a definition. Few of the things like a broad-based KP, mutton fat type of a KP, posterior synechia which is broad-based, and posteriorly you see a phlebitis close to a venous occlusion or a nodule which is classical, which he has described, those are the things where you can blindly think at as a clinical diagnosis.
There are only
please.
empirical treatment you could possibly do.
There are only two scenarios. So one, when you have a definitive lung patch, then believe me, the situation is out of your hands. It is the pulmonologist who says that he will give AKT for 6 months or 1 year, right? The second and the most important thing is when you don't have any pulmonary evidence or evidence of pulmonary cause. That is when you ask the TB specialist or chest person whether you should give AKT. And generally the reply is not from my side, but if you feel that we should, that is when the decision is yours. Those things he has given, and more often than not, it is not very definitive diagnosis, but it is a diagnosis of exclusion. Means you have excluded all of the causes, and now you find. And third thing is, in India, the most important cause is tuberculosis.
Well said. You have any comment? No. Yes.
No, we were talking about presumed ocular TB. So there are multiple signs. The active diagnosis of TB is very difficult because we cannot actually retrieve the bacilli.
Actually, till you prove it otherwise, rather.
So there are a few symptoms which sir was saying. So conclusively, if there is a broad-based posterior synechiae, or there is a vasculitis with patchy choroiditis along the vessels, old or active, or serpiginous like choroiditis, together they have 84% sensitivity that it can be tubercular, particularly in endemic areas.
Sure. Thank you so much. May I request all the VOS members to please come on the dais and take a group picture. Please come. आ जाइए. So that will be one very. We'll all stand. Please come. आ जाओ. Yes, Vidarbha Ophthalmic. जय विदर्भ. पीछे आ जाओ ना, नहीं तो ऐसा करो सेकंड रो में आ जाओ.
Thank you very much, sir.
आ जाओ सेकंड रो में. See, this is the most highly populated. ये गलत है. आ जाओ. आ जाओ. Yes, let's give a very big smile. 3 cheers from Vidarbha Ophthalmic Society. आ जाओ. अरे, why you are delaying?
समोर young ophthalmologist एकदम से पीछे चले गए एकदम से.
Thank you so much. Thank you everyone.
एक मोबाइल पे लो.
हाँ चलो.
Thank you.
चलो, thank you so much.